Okay, so you've heard the words thyroid nodule. And yeah, that can be a pretty stressful thing to hear. But what if I told you there's a clear, evidence-based roadmap that doctors follow? Well, in this explainer, that's exactly what we're going to do. We're going to walk through that roadmap step by step using the official guidelines from the American Thyroid Association so you know exactly what to expect.
First things first, let's get some perspective. Just how common are these things? Well, it turns out they're incredibly common. High-resolution ultrasound studies show that up to 68% of people have them. So if you've got one, you are in very, very good company.
And here's the number that really matters, the one you should hold on to. You know, that word nodule, it can sound pretty scary, but the data shows that only about 7 to 15% of them are actually cancerous. That means the vast majority, we're talking 85, maybe even 93%, are completely benign. Right, so you've been told you have a nodule. What's next? The great thing is, this isn't some big mystery. It's a really logical sequence of steps, and it's all designed to get clear answers while avoiding any unnecessary procedures. So let's break that journey down. First up, a very common finding. The fact that this is such a common thing for doctors to see is exactly why these super clear guidelines even exist. So the group behind this whole process is the American Thyroid Association, or the ATA. They've gathered all the top experts in the field to create these guidelines. Think of it like the official playbook for dealing with thyroid nodules. It's all about making sure every patient gets consistent, science-backed care.
All right, Section 2, your first evaluation. This is where things really kick off, and it all starts with a very simple, very straightforward first step.
So, the very first thing that happens isn't some complex scan or a biopsy. Nope, it's a simple blood test. And what they're looking for is your thyroid-stimulating hormone level, or TSH. This one number gives a really crucial snapshot of how your entire thyroid gland is working. Now, this is where it gets interesting, because that TSH level basically creates two different paths. If your TSH comes back low, it suggests the nodule might be overproducing hormones. They call that a hot nodule. And the great news there is that these are almost never cancerous, so you'd go on to a totally different kind of scan. But for most people, the TSH is normal or even high, and that leads us right down the main pathway to the next step. And here it is, the whole roadmap in one single flowchart, taken right from the ATA guidelines. You can see that TSH level we just talked about is right at the top, directing all the traffic. It just goes to show you this isn't guesswork. It's a very structured algorithm. Okay, so for everyone on that normal or high TSH path, the next phase is all about getting a closer look. This is where we start gathering visual clues from the nodule itself. And the best tool for that job, hands down, is a thyroid ultrasound. It's completely non-invasive, and it gives this incredibly detailed picture of the nodule's size, what it's made of, like is it solid or is it filled with fluid, and a bunch of other key features that help doctors figure out its risk level. Based on what the ultrasound shows, radiologists will classify the nodule into one of 5 patterns. It's a whole spectrum, right? It goes from benign, which has basically 0 risk of cancer, all the way up to high suspicion, which has a pretty significant risk. This classification is absolutely crucial because it determines everything that happens next. So what are they actually looking for? Well, it's kind of like being a detective. They're looking for a combination of features. Things like tiny little calcium spots, what they call microcalcifications, fuzzy or irregular borders, if it's taller than it is wide, or if it's mostly solid. Each one of those is a potential clue that can raise the suspicion level.
And that brings us to the big decision point, to biopsy or not to biopsy. The answer really depends on 2 things: how suspicious the nodule looks on that ultrasound and how big it is. As you can see from this table, the bar for doing a biopsy changes depending on the suspicion level. A high suspicion nodule, they might check it at just 1 centimeter, but a very low suspicion one, they might just watch it until it gets bigger. It's all about balancing the risks.
So for any nodules that hit those specific marks for both suspicion and size, the next step is the one that gives us the most definitive information we can get, the biopsy. This procedure is called a fine needle aspiration, or FNA for short. The official guidelines call it the most accurate and cost-effective method available. Basically, using the ultrasound to see where they're going, a doctor uses a very thin needle to grab a tiny sample of cells right from the nodule, and then those cells get sent off to a lab to be analyzed. So, the FNA is done. Now we're at the final part of this whole diagnostic journey, figuring out what those cells are actually telling us.
Now, to make sure everybody is speaking the same language, the results are always reported using a standardized framework. It's called the Bethesda system. This just makes sure that a report from a lab in one state means the exact same thing to a doctor in another. It's all about clarity and consistency.
The Bethesda system actually has 6 official categories, but to keep things simple, they really boil down to 3 main outcomes. The result can come back as benign, which is fantastic news. It can come back as malignant, which gives you a very clear diagnosis, or it can land in this gray area called indeterminate.
And this chart really puts those categories into perspective. A benign result, that means the risk of cancer is less than 3%. It's super low. Malignant, that means the risk is over 97%. And that indeterminate category, well, it means the risk is somewhere in between. The cells look a little unusual, but it's not totally clear if they're cancerous, so it needs a closer look.
So what happens for each of these? Well, for a benign result, the plan is usually just to keep an eye on it with an ultrasound every so often. For a malignant result, the usual recommendation is surgery. And for that indeterminate result, that's when you have a conversation about options, which might mean more advanced testing on the sample or even surgery to get a final answer.
But here's something that shows a really modern shift in thinking. The guidelines now recognize that even if you get a cancer diagnosis, especially for a very small, low-risk type of thyroid cancer, immediate surgery isn't always the only answer. Some patients might actually be great candidates for something called active surveillance, which means just monitoring it closely instead of rushing to operate. And that idea is captured perfectly by this quote, straight from the ATA guidelines themselves. A major goal is to avoid overtreatment. This whole process isn't just about finding cancer, it's about making sure the treatment actually fits the risk, which prevents potential harm for the huge majority of patients who are at low risk. So, what's the big takeaway here? Evaluating a thyroid nodule isn't some random walk in the dark. It's a well-defined path. And knowing these steps, from the first blood test to the final report, it empowers you to be a real partner in your own care. So now that you have the roadmap, what's the first question you're going to ask your doctor?